All right, yes, good afternoon, everyone. My name is Amanda Williams. I'm the Director of Population Health, Bundled Payments, and Post-Acute Care. Long name, amazing results, right? We'll see. So I'm here to discuss the cardiac bundles. How many of you have heard of this program before? Raise your hand. Okay. How many of you know that we're participating in this program currently? Okay, great. So this might be a review for some of you, but this is going to be brand new information for others. So I'm glad I'm here. So we are going to talk about, again, the cardiac bundles, and we started this program on October 1st of 2018. So we're currently about 5 months into the program, and we're still alive, so that's really good news, right? So I'm going to just provide a very high-level overview of some of the landmark changes that are happening in healthcare right now, so you understand what's driving all of these changes. And if you're asked to do something a little bit differently in your workflow, I want you to understand again why that's happening, because I know there's a lot of changes, and I know you guys are really feeling that. So I think having the big picture will be really helpful. Then we'll talk a little bit about the methodology for the bundles, and then we'll talk about what we're currently doing to ensure that we are going to be successful in this program. So on the screen, you can see a picture of, this is visual representation, I guess I should say, of what our healthcare system looks like today. It's siloed, it's fragmented, it's very complex. And in this country, when patients encounter or when they engage in healthcare, it's often when they're sick. So we call that sick care or rescue care. So if you can imagine as a patient, if you don't have any healthcare background, or maybe you have a cultural barrier or a language barrier, and you're trying to navigate this already very complex system, it can be even that much more difficult, right? And so maybe you've asked yourself during your career, as I did many times when I was a nurse on the floor, why we've created this really fragmented and siloed system. We're in healthcare, so we are really here to help and heal people, right? So part of the answer to that is how we get paid in healthcare. Did you know that? It seems kind of crazy, but we currently operate under what's called the fee-for-service reimbursement model. And this is really just exactly what it sounds like. We perform a service, and there's a fee associated with that service. So we draw a lab, there's a fee, a provider sees a patient, we drop what's called an evaluation and management, CPT code, and we bill the insurance companies for that. So we have all these different claims going out on the patients for each separate service that we provide. And this reimbursement model is criticized really for doing a couple of different things. The first one is it incentivizes treatment, even if the treatment may not be necessary, and it creates waste and overutilization of healthcare resources. So in this country, we have been operating under this fee-for-service reimbursement model for, I don't even know how long, decades, years, I'm not sure. But then a few different things began to happen, and I like to call this the perfect storm, because all of these things kind of started combining and adding up together, and it really made the case for change or reform. Payment reform is what we call it. So the biggest catalyst for change in how we get paid in healthcare is because of the baby boomers. They began to age and near the age of 65. And the baby boomers are our nation's largest living adult population. And what do we know? What happens when you turn 65? Medicare, thank you. You qualify for Medicare. Bud has seen this presentation before, so he gets it. Yes, you qualify for Medicare. And this is important because as we age and near the end of life, we become sicker, we have more chronic complications, and we consume more healthcare resources. And Medicare has to pay for this. And because this is such a large population in our nation, there's more people that are aging into Medicare than there are younger generations that are filling that Medicare bucket back up. And then the second thing, so if you see my graph, the people graph, these are kind of out of order, but this is just how they fit on the side. This graph right here. In 2014, 4 out of 5 people who died in the United States were covered by Medicare. And that's a large number of people, and that's a huge amount of healthcare resources. So the second graph that I would draw your attention to is this one down here. Can you see it? The graph with all the lines in different colors. Can I do it? This is healthcare spending as a percent of GDP. So we are here, we're the black line, and this is how we compare to other developed nations. So we're spending a lot more on healthcare than other developed nations are. And when you look at things like our quality outcomes and access to care, which is up here, the top left, we're down at the bottom compared to other developed nations. So this is really telling us that we're spending a lot of money on healthcare, but our patients aren't necessarily getting any better. And then, if that wasn't enough, in 2012, I want to say, the Institute of Medicine, so a society within our own profession, published a white paper that estimated that about 30% of healthcare cost is waste. So 30 cents of every dollar that we spend in healthcare is waste. So what is an example of waste? That is the overutilization of resources and unnecessary treatment. Fraud is a piece of that too, but that should kind of ring a bell of what we talked about with the fee-for-service reimbursement model. So all of these things are coming together to create that perfect storm, and it's really leading to this. Medicare is projecting that they will run out of money by the year 2026. Now, I don't exactly know what our payer mix is at the hospital, but I think it's usually our Medicare patients make up about 50% of our patients. And that's probably maybe 30, I mean, somewhere around there. That's probably pretty standard across the nation. So you can imagine if 30% of patients across the United States lost their healthcare insurance, that would absolutely cripple our healthcare system, right? So Medicare is currently doing everything they can to do two things. One, contain the cost of healthcare resources, and two, keep the quality of the care that we provide our patients high. This is not about cutting care to make it cheaper. This is about becoming more efficient and removing that waste out of our processes. So this is where the value-based reimbursement model comes in, and this model is really looking at, again, cost and quality. It's designed to be more patient-centered, improve health, decrease that fragmentation, especially between acute and post-acute care partners, improve our quality outcomes, lower costs, and we're really going through this shift in healthcare where we are in that rescue or sick care and shifting to prevention and wellness. You know, we're not used to seeing our physicians or our providers when we're sick, right? Or when we're well, we do that when we're sick. So we're going to start seeing more wellness and prevention efforts. So this brings us to the bundles, and the bundles are a slice, kind of how I like to explain it, of this bigger value-based reimbursement model. We're participating in 3 clinical episodes. They're all cardiac-based episodes. So a bundle really is looking at an episode of care and bundling all those payments together that would be covered under Medicare Part A and Part B, so the hospital and the outpatient side, bringing them together and then evaluating a cost target and quality outcomes, and then determine if you've been quote-unquote successful in moving that patient through the continuum of care. So for example, when a patient gets hospitalized at Jenny Utter Methodist Hospital and they discharge under one of the AMI or CHF MSDRGs, that triggers the bundle. And then Medicare will follow that patient to 90 days post-discharge and look at all the healthcare services that were paid by Medicare. And they include everything, including ED visits and readmissions to health systems outside of our own. It can be anywhere in the nation. Skilled nursing facility is included in that, home health, provider visits, durable medical equipment, and hospice. You can see on the bottom of the slide there's some readmissions or exclusions for readmissions. They're very, very few and far between, so we just assume that if a patient gets readmitted during that 90 days, the cost of that readmission will be included in their overall bundle price. Does that make sense? Any questions about that? So again, this is not about cutting costs, it's really balancing the quality, or cutting care, it's balancing the cost and quality, becoming more efficient, moving that patient through the continuum of care, and it's really getting aggressive in managing that chronic condition on the outpatient side, so we can avoid readmissions, ED visits, that kind of thing. So Medicare has some quality measures that they're looking at, and again, the cost targets. So for example, and this is a very large overgeneralization, there's much more complexity to this, but if Medicare says your CHF patients, you should be able to move them through that 90-day episode for $10,000, and then we look at the quality measures. You must also be successful in the quality measures, which are listed up there. Some of them are not specific to CHF. Just FYI, we're trying to figure out how like PSI 90 fits in there. But and then they'll say, okay, so if you move this patient through the continuum of care and it costs $12,000, you weren't successful, and we could actually owe Medicare money in that instance. If we move the patient through that continuum of care and it costs $8,000, and we hit the quality measures, of course, then we were successful, and we could get shared savings or money back from Medicare. So that's really how that works. So we decided to participate in these 3 clinical episodes, the AMI, CHF, and outpatient PCI, because it would provide a variety of experience, but still very manageable. So we have some inpatient and outpatient experience in medical and surgical. And then we also had a really good existing infrastructure that consisted of the cardiovascular, is it the steering line committee? So cardiovascular service line steering committee. And this has leadership from both the hospitals and the clinics. So this is a good structure that was already in place. So these are kind of the reasons why we looked at these 3 clinical episodes. I think there were a total of 35 that we could have chosen from. And in addition to that, Medicare gave us 3 years of historical claims data. And claims data is really important because it gives us that entire picture of the patient, because they're paying for the patient regardless of what health system they go to. And that also helped us make our decision. So if you look at it, the red is CHF, and that's where we would be unfavorable compared to the cost targets. And so we're favorable in AMI and PCI, and then we have some room for opportunity for CHF. That's really what that's saying. So we did that because, quite honestly, if we did absolutely nothing, we still think we would be successful in this program, right? But Medicare's not going to go for that. So they asked us, as we were completing the application process, they asked us to identify what's called our care redesign drivers. And some of you in this room are very, very familiar with those drivers. And they're listed on the board, but this is our plan. This is the process changes that we as a health system are going to make to ensure that we will be successful in this program. This bundled program that we're in, it's part of the CMS Innovation Center, and so they're really gathering data on what health systems are doing to be successful. And successful is lowering costs and keeping the quality really high. So what we're doing, actually I'm going to go back. What we're really doing is we're starting with the CHF because that is our biggest area of opportunity. And we've really revamped the CHF PI work group. And all of these care redesign drivers exist under that work group. And what we're really doing is we're creating a systems-driven approach to how we manage our CHF patients across the entire continuum of care. So we have work groups under the CHF PI committee that are looking at advanced care planning. That's one of the quality measures. We're looking at clinic capacity. How do we do same-day appointments? Do we have the capacity for that? Because again, we don't want to send that patient to the hospital if we can manage that condition in the clinic. We're looking at inpatient order sets, going back and updating that order set and then getting providers to actually utilize that order set is kind of the next step. So that's the kind of work that's being done currently. We started with CHF, again, because that was our biggest opportunity, and then once we get at a good point with that, I think we'll scale some of that work out to AMI and then outpatient PCI. So as far as next steps, operationalize the care redesign drivers. We just talked about that. We have a post-acute care collaborative with 12 SNFs, skilled nursing facilities in Council Bluffs, Fremont, and Omaha. And that's really looking at that readmission and length of stay because when it comes to the episode and when you look at the entire episode, SNF utilization is a very high cost driver for that episode. So we really need to begin partnering with our SNFs and understanding how we can get our patients out a little bit earlier, how we can partner with them to help with the readmissions back to the hospital. So those are some different things we're looking at collaborative. We have bundle waivers. I think that's kind of a 2020 thing for the future to start figuring out how we really operationalize those. And then we need the data. Medicare is giving us monthly claims data. It's slow, but it's way faster than they have ever given us data before, so that's super exciting. And we need that data just to understand how we follow these patients through that continuum of care, because again, we want to manage those patients very aggressively on the outpatient side, so they don't have any readmissions or ED visits. And when we get really, really good at this, you guys, the intent will be, let's push that back even further and prevent that initial hospitalization from ever happening. We're not there yet, and that's kind of a dream world. I mean, we'll always have patients in the hospital, right? But that's really the idea that we're working towards here. And Medicare is really driving this, again, because they're run by the federal government. But if 30% of healthcare cost is waste, the commercial payers don't want to pay that 30% either, right? So they're not as engaged with the value-based contracts right now, but we see more of them coming, and we just expect that trend to continue. So I know that was a ton of information. I'm done. So if you guys have any questions, please let me know. Clear as mud? Okay, great.